Hi there, and excited to bring to you the UBMD Family Medicine Pharmacy Team iteration and presentation for the 2022-2023 longitudinal rotation application. We're very excited to engage with all of you guys in this great opportunity. So I am joined here today, myself, Dr. Daly, along with Dr. Foster, who's been instrumental in our service growth. We are a relatively newer ambulatory care service when you look at different services within the Western New York region, but one that is very robust and has a lot of great opportunity for you to consider as you weigh different options for next year. So we're going to go through this agenda, meeting the pharmacy team, description of rotation, our specific offerings, and then we're going to take you through one of our interventions and how we think about and approach patient care overall. So our model, myself as team, we also have Dr. Foster completing her 2-year postdoc with us, and she'll explain a little bit more about that and next steps. But we want you, we have what we would consider as a layered learning model, where we have pharmacists involved, but also APPE students in the form of 6 and 12-week rotations. And that would be in the form of a core and elective rotation, but we really do well to merge those 12 weeks together and give you a lot of opportunity in the form of presentations, writing, and clinical opportunities as well. You'll also be engaging with IPB students, and that means some of you currently that are coming on site with us. And we typically have the students with us 2 days per week during the module to help specifically with their more high volume work overall, but also a lot of great learning opportunity as well there. And Dr. Foster, why don't you share us a little bit more about yourself and the opportunity for growth here?
Sure. Hi, everyone. My name is Dr. Amanda Foster. Like Dr. Daly mentioned, I am currently completing my second of a 2-year postdoctoral clinical research fellowship with the School of Pharmacy with Dr. Jacobs and Dr. Daly. So I'm really focused in health services outcomes and research. And as part of that, I am a clinical pharmacist with UBMD Family Medicine and Dr. Daly. So I'll be working with all of you, which I'm really excited to do. And trending towards the end of my fellowship, our goal is to create a clinical pharmacy position within UBMD that would allow me to transfer to that position. So I would still be working with everybody, just in a different capacity. But our students are really our drivers of this model and where all of the work really gets completed. So we lead you through and guide you through, but our APPE students really drive our service right now. So you would still be working with both Dr. Daly and myself. I just might be switching roles. So we're really excited to work with you guys.
Perfect. And we do a team-based approach. So the advantage of us is we're faculty preceptors and we co-precept in a lot of instances. So you get that type of insight into that. So, there's the website on what UBMD Family Medicine is. It's one of a couple dozen. I think there's almost 24 business units for UBMD. You hear it all over town. Well, we're family medicine, right? And within that, there are 4 locations: Amherst, Sheridan, Conventus, and UBMD at Best South on Niagara Street on the west side of Buffalo. So the areas in yellow are really what we've grooved kind of the opportunity to be currently. When we're on site for clinic, which is in all 5 days of the week. That's going to be at Sheridan location. And then we do operate out of the School of Pharmacy, typically on Fridays for more of a call center type outreach, where we are able to do more of our project work, because there's a lot of different types of projects that are very well diversified, I feel, with the service as well. But Dr. Foster, why don't you tell us a little bit more about the team that we work with at UBMD Family Medicine?
Sure. So as Dr. Daly was alluding to with a lot of our projects, we work with our quality team and Casey Schroeder. She is an excellent person to work with. She provides us with a lot of quality metrics and programs to work on, from adherence to cost effectiveness. And there's other projects that come down the pipeline as well from some of our insurers. So we really work closely with her to get rosters to run our projects. In addition to Casey and the quality team, we also work with social workers. We have a dietitian on board that we can refer to. We work with, there's an NP and a PA at our practice site, as well as many nurses on our clinical team. And we actually were able to pull one RN into our pharmacy team more and incorporate her into more of our projects. And she's been an integral role in helping us complete our projects and maybe reach out to patients in a different way than we normally would. So she's been super helpful in helping our students as well as us kind of reach our goals with our projects. And of course, we also work directly with our providers. So you'll be communicating directly to our providers, whether it's in our task queue or if you're in the office, you'll also be face-to-face with the providers, consulting with them, providing them drug information, going in to see their patients with them. So we're very heavily focused on interprofessional collaboration at UBMD. A lot of our providers are academically focused, so they really strive to incorporate the medical students as well as the residents with our pharmacy students, as well as the whole care team. So that's just a little bit more about who you may see at our practice site when you come to work with us.
Perfect. And as far as the services, this is not necessarily the entire list, but one that we do spend a lot of time on. And as mentioned, it's a very diversified list of services. So when we say comprehensive medication management, we really do get involved in, think of the wheel, the patient-centered care process and all those different elements when it comes to diabetes, deprescribing. So that's trying to get, patients 65 and older off medications that are potentially inappropriate. COPD, we have an intervention as well. So that really is the continuum of patient care and where we're involved in that process as well. MTM, that's a Part D metric. We do have targeted interventions that we need to do. And this is a real practice. They need to keep their doors open. So there are quality metrics. And by us doing it, I feel we do it very thoroughly because we have access to the EMR, we have access to providers, so interventions can be made in a different light as well. The day-to-day, students are very involved in more of the consult tasks, drug information, patient education, cost-effective prescribing is a big bucket for us, and medication reconciliation, because as we find out, the health status on patients are greatly related to their medications, and that changes quite frequently from time to time. So having an accurate list of the medications is really important to our practice, and they make that a priority. Dr. Foster will talk about transition care in the right-hand column.
Sure. So one of the programs that's a little bit newer to the pharmacy team is the Transitions of Care program. So we do have a Transitions of Care nurse who is assigned to work with all of our transition of care patients, schedule follow-ups with them. And if she notices anybody that may need some additional help with their medications, she'll then refer them to us. So some patients that you might see are patients with multiple chronic comorbidities. So things like diabetes, CHF, COPD, asthma, other cardiovascular complications, as well as patients who may be experiencing hyperpolypharmacy and may not appear to be adherent or really understand their medications, along with any patients who are on the ISMP high alert drugs, so things like insulins and anticoagulants. So what we'll do is we'll do a complete medication review with the patient to make sure everything is accurate and everybody is on the same page with what they're supposed to be taking, as well as some counseling about the medications. And sometimes we may even provide follow-up to the patient or provide recommendations to the provider regarding what we find in the initial intervention. We also have program metrics that we were discussing previously. So a large focus of our interventions that comes from the insurance companies is going to be adherence. So we focus on adherence specifically for RAS inhibitors, so ACEs and ARBs. Statins are a big one, as well as oral diabetes drugs, specifically metformin, and we're starting to do some GLP-1 work as well. In addition, we are also focusing on patients who have diabetes and need a statin on board but have not been taking one or have not been prescribed one. So we'll work with those patients to counsel them and get them on board with a statin. And we also work on cost-effective prescribing, especially with inhalers, and diabetes medications have been our big two. In addition, we also have our students help us with our provider, resident, and clinical team education. So with a longitudinal student, you will present an in-service to our providers, as well as residents and anybody else from the clinical team who would like to join. And every module, you'll also create a Pharmacy 5 newsletter, which is a pharmacy-focused outpatient care newsletter that has 5 topics that the providers can update their knowledge on in 15 minutes or less.
So why choose us? We invest in our students, we invest in you, and we promise to take the time as faculty preceptors, which is a little bit different, to invest in your professional goals. So we always ask, where are you heading? What are you trying to do? How is this going to align? And how do we best move to those next steps with you? And I'd like to think we have a balanced approach with education, clinical, and research opportunities. So that's going to be the day-to-day clinical exposure, the educational opportunities, as Dr. Foster just mentioned overall. And if you're a 12-week rotation, we'll work with you to do a presentation in what we call in-service to the providers. That's a great CV ad, especially if you're looking to go to the next steps and show that type of skill. There, of course, will be special projects. We train our students, we have outside speakers come in topics like motivational interviewing, because a lot of those techniques are being involved. And one of the great reasons to invest in you is topic discussions. And you're going to see one of our interventions next that we cover really does involve you to know in-depth knowledge of something that's pretty common disease state in diabetes, but you have to become almost an overnight expert in it. So we utilize topic discussions to do that. And then research. We have a lot of longitudinal projects that are greater than even the 12 weeks. So if that's something that's of interest to you, really do need to reach out to us as soon as possible so we can line up, whether it's a 598 or some other activity to align you into a program like this as well. So yeah, Dr. Foster, anything else to add before we go into our diabetes intervention?
I really think too, one of the values from our program is that no matter what career setting you're looking forward to going into, we really do cover topics from every area. There's a lot of focus with outpatient. So if you want to go into community pharmacy, we do teach you a lot of skills with medication management, MTM, a lot of insurance navigation. Ambulatory care is our primary focus with what we do here. But there's also inpatient experience that you'll gain with our transitional care program, as well as some of our other projects and programs as well. So it really is a well-rounded experience, regardless of what career path you're thinking about choosing. Managed care as well is another where our students feel like they benefit from our rotation, just from the sheer amount of insurance and quality related projects that we do, and insurance navigation and cost effective interventions we provide as well.
Perfect.
All right, so now we'll kind of go into one of our large interventions. It's one of our bigger projects that lies on the shoulders of our APPE students when you come in. So we have a diabetes intervention. We call it our just-in-time intervention. We'll go through the workflow in the next slide. But why this was created was we have the Optum Physicians Alliance, which is our group of insurance companies who sends us metrics and projects to keep ourselves on board and meet STAR measures. So we have Independent Health, Blue Cross Blue Shield, Univera, and some others come in and out as well. So a big focus is maintaining a hemoglobin A1C of less than 9% in all of our patients with diabetes. Also optimizing anybody who has diabetes to have metformin up to 2 grams per day as appropriate based on renal function and tolerability as well. They do consider that. We have a big push to prescribe our DPP-4 inhibitors. That's one of the things that we go over in our diabetes topic discussion on why we want to do that due to cost and more efficacious agents regarding cost. So the other options that we do is we kind of work through our diabetes algorithm, which we'll show on the next slide as well. If I can just have you scroll over to that. So this is our workup process. What we'll have you do is we'll have you look up the patient. You have access to all the labs that are in the chart, which is really nice when you're working up a patient with diabetes. So not only are you able to see what their A1C is, sometimes you'll be able to pull a fasting blood glucose panel based on the most recent lab that was drawn. And we always have their most recent renal values on board too, which, as you guys know, is important with diabetes in general, as well as some of the medications that we need to dose based on renal function. So based on all of these labs, we need to primarily see if the diabetes is currently controlled or not. So does their blood glucose look controlled? Is their A1C at goal based on those ADA and AACE guidelines? And then we want to look at what they're currently taking and see if we can perform any interventions to get them back on track with their A1C and blood glucose control. So once we do that, we kind of task our provider with our findings and suggestions. Usually the provider will take those notes and discuss it with the patient during the appointment. A lot of times we will see an acceptance of our recommendations, and then we follow up to work with that patient to make sure that those recommendations are being carried through and keep the provider updated on the status along the way, just to make sure that if there's any dosing titrations that need to occur, or a patient is not tolerating one and we need to try another option. So we work with our patients to get them as controlled as possible and as comfortable with their medication regimen as possible. And that takes a lot of direct communication with the patient and the provider, and our students are very key in maintaining that process. So these are some things that we're really looking for with our diabetes interventions. So the first thing we always want to check for, and this is like a big part of our topic discussion, is how to navigate the ADA pharmacotherapy algorithm. So first thing, gold standard of therapy, is the patient optimized on metformin at 2 grams per day if they're able to be? Have they been taking it regularly? Is there an adherence concern? If they have, that's great. If they're optimized, that's great. And then we move on to the next thing. Another big part of our intervention is to make sure that a DPP-4 is deprescribed. So we always move to deprescribe our DPP-4 inhibitors, and ideally we want to switch them to a GLP-1 agonist or an SGLT2. While they will be about the same cost of a DPP-4, we not only get better A1C lowering, but we also have many other beneficial effects. So that's another reason why we want to deprescribe DPP-4s, is for cost effectiveness versus drug benefit. And then once we navigate through those options, do we have a need for additional therapies? So where is the patient at in that ADA algorithm, and where can we help them optimize their medication regimen between titrations and additions? And a lot of other things come into play with that. So comorbidities come into play, cost comes into play, patient preference comes into play. So there's a lot of things that we teach you how to navigate many situations that are patient specific, which will really help you with your clinical decision making and clinical application skills.
Thank you, Dr. Foster. And you were very instrumental in getting us to this point with this algorithm. So really what you see there is we take care of patients, right? And we teach you the trains of thought that are needed in order to do that clinically, but then we have to communicate to the patient, and it has to be a plan that they're able to execute as well. So thank you for your time today. I know we talked to you in detail what our site is. So if you have any questions, here's our contact information. We're more than happy to talk with you. Even if you want like a meeting with us, or you want to come see us on a Friday just to discuss what we do, we'd be more than happy to have you come out and go into more and more details there. So thank you. And we hope that you guys consider us. Take care.
Thank you.